Okay, so we will see today development of the body cavities. Yes, please settle down. And the diaphragm. What are the body cavities we are getting in the developing embryo? Okay, so we know what are the cavities lies in the adults. Pericardial cavity, pleural cavity and peritoneal cavity. Does this space or cavity, can you see how large it is? Yes. So it's a potential space. We can't see the space here, but if something gets collected there, there is that is collection in that space. Okay. And this space or this cavity is lying, the walls are very close to each other. One is visceral and one is the parietal layer. No discussion on the back side. If you wish, you can leave. No attendance. This is the competency, okay? 52.5 describe the development and congenital anomalies of the diaphragm. So we are knowing there are three body cavities, right? Pericardial cavity, which is developing in relation with the heart. Pleural cavity is developing in relation with the lungs. And the peritoneal, which is developing in relation with the abdominal viscera. So how these cavities are formed? Okay, how it is forming? So two spaces appear. The first, we know in the last session we have seen the intraembryonic coelom. That is the space, horseshoe shaped space appears in which layer of mesoderm? Yes. Which layer of the mesoderm? Lateral plate mesoderm. It's not reading. Yeah? And what happens along with these? In this space, the membranes are produced or partition is formed. How? The partitioning we will see. Due to partition, these cavities are developed. So in short, we'll just revise the formation of intraembryonic mesoderm. How it forms and how is the space develops there. Developing embryo, right? Cranial end, caudal end. Here, what is this? What is this? Precaudal plate. And what is this? Cloacal membrane. This is the connecting stalk. So here, after formation of primitive groove, yeah, primitive stick and all, it induces formation of the middle layer, that is the mesoderm. So here, trilaminar disc is formed. Why there is discussion? Continuously, silence please. So what happens here? We are getting the trilaminar germ disc. This, after formation of the mesoderm, the intraembryonic mesoderm is lying on either side of the neural tube, developing neural tube, and that is thickened to form these three layers: paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm. Just near to the neural tube, what we are getting here? This is the paraxial mesoderm. Lateral to that, intermediate mesoderm, and most lateral is the lateral plate mesoderm. What this paraxial mesoderm is forming is, in last lecture we have seen that. Somites. What is formed from the intermediate mesoderm? Urogenital system. And rest of the mesoderm is forming the all rest of the part of the body. So what is, how the coelom is formed? First, there is the appearance of the small spaces in a horseshoe shaped area in the lateral plate mesoderm. So here we can see in this image, these spaces are becoming continuous with each other, right? These spaces fuses and forms a horseshoe shape area here, that is the gap or the space inside the lateral plate mesoderm. So one large single space we are getting here, and that is named as the intraembryonic coelom. Understood? So during the fourth week, we are getting this horseshoe-shaped intraembryonic mesoderm, the schematic picture which is depicted here, which is having the anterior part, cranial part, just behind the septum transversum and anterior to the precaudal plate, right? This is the cranial part of the intraembryonic mesoderm, intraembryonic coelom, and it is having two limbs here. These two limbs also name as the coelomic ducts. So anterior to the cranial fused part of the intraembryonic mesoderm, coelom, we are getting this septum transversum. So this cranial most part which is fused here anterior to the precaudal plate, that is forming the pericardial cavity. Okay, that part is forming the pericardial cavity. What we can see here, this intraembryonic coelom is communicating with the extraembryonic coelom. Why there is need to communicate? So there is a free communication between the intraembryonic and the extraembryonic coelom. What is the reason? Yes. Does the blood vessels develop here? So for nutrition from the amniotic fluid, in the extraembryonic coelom, what we are getting? Amniotic fluid. So it is flowing along with the intraembryonic coelom. So here we can see the free communication. But later this is closed. How? After the absorption or taking inside the intestine which was herniated. After that, this communication closes between the intra and the extraembryonic coelom. So here in a transverse section we can see this is the communication. So due to this formation of this space, the coelom, the mesoderm, okay, lateral plate mesoderm is now divided into the two layers. The part of the mesoderm which is related with the ectoderm is named as the splanchnopleural layer of the lateral plate mesoderm, while the mesoderm which is in relation with the endoderm is named as the ectoderm is the somatopleural layer, which is related with the endoderm is the splanchnopleural layer. Okay. So this splanchnopleural layer related with the endoderm forms the visceral peritoneum, visceral pleura or visceral or serous layer of the pericardium. Okay. While whatever the somatopleural layer which is related with the ectoderm contributes to formation of the body wall, parietal layer. Parietal layer is forming from the somatopleural layer. So as it is related with the body wall and developing related with the ectoderm, the somatopleural layer is sensitive to pain. It is supplied by the spinal nerves. While this somatopleural layer which is supplied by the autonomic nervous system, right? So that is not sensitive to pain, but it is sensitive to dragging, traction, right? So that is how we have seen now how the horseshoe shape intraembryonic coelom is formed. First, there is the communication between the intraembryonic and the extraembryonic coelom. Later, it is closed, right? Now, what we are getting a single large cavity in the lateral plate mesoderm. Now, till now, there is no head fold, tail fold or lateral fold. Only disc is present. How is the embryo? Only one disc. Now, in this space, there will be the partitioning. In the intraembryonic mesoderm, the various partitions are formed to form these cavities. So we know this intraembryonic coelom becomes the embryonic body cavity which is divided into these three well-defined cavities. During what age? During the 4th week of intrauterine life, right? It's so early, so during 4th week. So we know the cranial most part of this horseshoe-shaped cavity is forming the pericardial cavity, while these lateral limbs which is connecting this primitive pericardial cavity with the primitive peritoneal cavity, these two limbs are named as the pericardio-peritoneal canals. Pericardio-peritoneal canal forms the pleural cavity. While this coelomic duct, which is the rest of the part of the this intraembryonic coelom, it gets fused to form the peritoneal cavity. Okay. So what is happening here? The canals that connect the pericardial and peritoneal cavities are called as pericardio-peritoneal canals now here. So when you take this space outside, we can see the shape is like this, and this is the communication between the pericardial and the primitive peritoneal cavity. Okay. Now we'll see how the further partitioning happens. How the partitioning are formed? There are two membranes which are formed, pleuropericardial membranes. Okay? Pleuropericardial membrane and pericardioperitoneal membranes. These two membranes are formed, and the most important here, diaphragm is formed from different sources. Okay? So diaphragm is a partitioning between two cavities. So here when we see thoracic diaphragm, it is the diaphragm. Which are the other diaphragms in the body, you know? One by one. Urogenital diaphragm. Yes. Any other diaphragm? Yes. So that is homework for you. Okay, search the other diaphragms of the body. So first we will see how the pericardial cavity is developing. Right? So this is the schematic image of an embryo just before the head fold. How is the relations? When we see from the cranial to caudal side, the cranial most structure here is the septum transversum. Okay, after septum transversum, we are getting the cardiogenic area, in which anteriorly we are getting the developing heart. Behind that, we are getting a space that is the pericardial coelom. Later, we are getting here the stomodium, right? That is the precaudal plate. So it is covered here with the oropharyngeal membrane. Close everyone close your books. Whatever you are doing, close your notebooks, close your journals, and close your books. This is not the place to read or complete your journals. So how is the relations from cranial to caudal side? Septum transversum, the developing heart along with the pericardial cavity, precaudal plate, and then the pleural tube. Okay? Here, the pericardial cavity is dorsal to the developing heart. It is lying dorsal to the developing heart. Further, what happens? Head fold is happening here. After the head fold, the pericardial cavity lies between the stomodium, which was caudal side to the septum transversum. Now, stomodium is going towards the cranial side. So here we can see, after the head fold, after the forebrain or developing neural tube, we are getting the stomodium or the precaudal plate, which is shifted now, and the pericardial coelom and the developing heart. So how is the pericardial coelom here? Ventral to the developing heart. How was earlier? It was dorsal to the developing heart. And then after that we are getting the septum transversum. Right? So this is how the relations changes after the head fold. So cranial most structure here we are getting the forebrain, the stomodium, the heart and the pericardial cavity, and the septum transversum. Do you want to leave the hall? You are not kids, school going kids. Adults say sab log, right? We don't have to repeat again and again the same instructions. Please leave the hall, attendance bhi nahi milega. If you are not maintaining discipline, we have to force for discipline, right? No one is reading embryology. Nobody knows the earlier things. Still you are going on discussing or chatting. So this is how the relations changes after the head fold. Right? Understood everyone? Can anyone narrate what are the changes after the head fold? Can anyone narrate how is the relations before head fold and how is the relations after head fold? From the back side. So important chatting was going on, right? If you are doing the same thing, I will point out everyone. So what happens here? Somatopleuric layer of intraembryonic mesoderm forms the fibrous pericardium and the parietal layer of the serous pericardium. Right? So here we are getting the space between the parietal layer of serous pericardium and the visceral layer of serous pericardium, and that space is the pericardial cavity. Right? So somatopleuric layer of this mesoderm is forming the thick outer fibrous pericardium and the parietal layer of serous pericardium. While this planktopleuric layer of the intraembryonic mesoderm forms the visceral layer of the serous pericardium that is very close to the heart tissue, heart muscles. Okay, it's difficult to separate out from the heart wall. So that is how the cavity is turning into these two layers, right? Now we'll see the pleural cavities, how this is developing. We know here we can see this is the fetus which is viewed from the lateral aspect. Here we can see the forebrain vesicle which is developing. This is the pericardic cavity. From the pericardic cavity, it is communicating with the peritoneal cavity. This canal is named as the pericardio-peritoneal canal, right? So there are two, right and the left pericardio-peritoneal canals. So in the schematic picture below, we can see it is passing on either side of the foregut, right? Proximal end of the foregut here is forming the esophagus, lower part of the pharynx and the esophagus. So here we can see these pericardio-peritoneal canals are lying on either side of the developing foregut. How is the relations? The pericardial cavity is lying ventrally and the two pericardio-peritoneal canals pass on either side of the foregut, right? So pericardial cavity is anterior. So on either side of foregut, these two canals are passing. So why we need to understand here how the lungs are developing, from which germ layers? From which germ layers the lungs are developing? In the last session we have seen all the derivatives of the germ layers. Yes? There is something invaginating. What is invaginating? The lung bud. And the lung bud is arising from the foregut. So foregut is in the middle, a tube. On either side there are two pericardio-peritoneal canals. From the foregut, the two lung buds are arising and which is going towards the right and left side. Okay? So these two lung buds are invaginating in this pericardio-peritoneal canal from the medial to lateral side. Okay? Now once the bud are formed, it is formed from the endoderm. Okay? It is the endoderm part of the foregut. Right? Now these lung buds are enlarging. During the peritoneum, you have seen how the viscera or how the organs or the peritoneal layer are formed. The viscera is along with the peritoneum is growing inside. Right? Similarly here, the lung, like if you are taking a balloon and putting your fist in a balloon, okay, and deeping the, like you are extending inside. So how these two layers are becoming close to each other, right? And towards one side we are getting the hilum where we are having the wrist, right? So this is how it is extending and enlarging. So the lung bud is enlarging in the pericardio-peritoneal canal, right? That's how it deepens down these canals and the two layers are going close to each other. So in this image we can see the black arrow is showing the pericardio-peritoneal canal, in which yellow color structure that it is named here as the bronchial bud that will grow towards the lateral side. Now what happens? Once this is formed, the lung is growing faster. Now there will be the separation. How is it is getting separated? By formation of two membranous ridges or two what you called as the septi. What are these? With the growth of lung bud into the pericardio-peritoneal canal, a pair of membranous ridges is produced in the lateral wall of this canal, right? So this is the schematic image in which we can see the upper part here is the pericardial cavity and lower one is the peritoneal cavity. This narrow is the pleuroperitoneal canal. Towards the medial side, towards one side we are getting this septum transversum below. Now the two folds are formed. What are these? Pleuropericardial fold and the pleuroperitoneal fold. Right? Where we are getting this? In the upper part of the developing lung, we are getting the pleuropericardial fold. That ridge is formed in the wall of the coelom. While below the lung, developing lung, we are getting the pleuroperitoneal fold. Once these folds are formed, this gets thickened to form the membranes. Right? Yes. See here. This is the lung bud. Okay. This is the pleuroperitoneal canal. So in the pleuroperitoneal canal, two folds are formed above the lung. As the lung is growing, lung grow kar raha hai, enlarge ho raha hai. Due to that, there is the formation of these folds. Okay, towards the upper part, we are getting the pleuropericardial fold, and towards the lower side, we are getting the pleuroperitoneal fold. Okay. Now these folds are forming thickening. They becomes thickened and forms the membranes. Right? As the folds enlarge, they project into the pericardio-peritoneal canals. They are projecting and growing. Gradually, the folds becoming membranous. So, blue color here we can see pleuropericardial membrane. Yellow color is the pleuroperitoneal membrane. Now, eventually these membranes are separating the pleural cavities and the peritoneal cavities. Inferiorly here we can see the pleural cavity above, and the inferior peritoneal cavity is separated by this green color shaded area. What is that? Pleuroperitoneal membrane. So this pleuroperitoneal membrane is also forming the diaphragm, the part of the diaphragm, right? So it is also have a role formation of the part of the diaphragm. While this upper part, what is this? Pericardio-pleural membrane that is fusing with the septum transversum, right, below, and that is how it is forming the partition between the pericardiac and the pleural cavity. Now the lung is growing faster, right? So the pericardium is shifted slight towards the center, and right and left lungs are, as this is growing, the cavity becomes very narrow. That is the pleural space. That is between the parietal and the visceral layer of the pleura. Okay? Now what happens here? The pleuroperitoneal opening on the right side closes before than the left side. You just remember this because we are having the congenital anomalies which is more common towards the left side. So right one closes before the left one. Now these both membranes becomes continuous with the posterior border of the septum transversum. As I said, pleuroperitoneal membrane is forming already the diaphragm, right? And this pericardio-pleural membrane is also growing down, and it is fusing with the posterior part of the septum transversum, right? So they both are fusing towards the septum transversum. And what the septum transversum is forming? Yes? Yes? Diaphragm. Central tendon of the diaphragm, the major important part. So this is how it is fusing. The pericardium is coming above, right, and fuses and along with the pericardic cavity. So this is happening. This gets closes by the 6th week of the intrauterine life. Now overgrowing lung bud turns this pleuropericardial membrane and make it vertical. So here we can see this pleuropericardial membrane was oblique, right? Now here in the lower part we can see pericardio-pleural membrane here. It becomes vertical due to growth of the lung. From where the heart is developing? Which germ layer? Mesoderm. From where this lung is developing? Endoderm, right? So this is growing faster. Now here in this image, we can see this is from the Keithmoor. We are waving from the lateral aspect, the embryo. Embryo is the thoracic and the abdominal cavity. So here we can see the heart tube is in the pericardial cavity, and this upper membrane is the pericardio-pleural membrane, while here the greyish color is the lung bud which is growing, and it is separating from this the liver and the abdominal viscera by this pleuroperitoneal membrane, right? And the ventral part of that here is forming the septum transversum, and these two fuses to form the diaphragm, pleuroperitoneal membrane and the septum transversum. Okay. So this is again the image from the Keithmoor, so you can understand A, B, C, D. Just observe here, in the pericardio-peritoneal canal, we are getting this bronchial or the lung bud which is formed, which is growing towards the lateral side. This is how it is growing. So that this space is deepening. It is producing its space. It gets deepened here in the lateral thoracic wall. In image C, again we can see the space is growing and going towards the posterior side, right? While here we can see here is the pericardiac cavity, around which we can see the pericardium, which is separated by the membranes which is already fused here, and in the pleural cavity we can see the completely formed lungs, right? And it is having the medial side. What is this? The hilum. Okay. Now we'll see how the peritoneal cavities. We have seen pericardial and the pleural cavities. So two pleural cavities on either side of the foregut. We know there is a single peritoneal cavity. So you have dissected this. So how it is developing? Developing from the horseshoe shape, intraembryonic coelom. Which part? The limbs. Okay, and these limbs are also named as the coelomic ducts. Right? Later what happens? After formation of the anterior abdominal wall. Okay, after the lateral folds, these two limbs are coming very close to each other, and that gets fuses ventrally, right, to form the peritoneal cavity. So formation of lateral folds, these ducts, intraembryonic, the right and the left ducts of the intraembryonic coelom closes and they fuse with and form the peritoneal cavity. We know during development, the foregut is done, right? Foregut ho gaya theory lecture. So how the gut is folded towards the abdominal wall? Yes? You are not reading what the lectures are completed. So here what we can see, this is the primitive gut. Towards the dorsal aspect we are getting this notochord, right? And here what right and left halves of the peritoneal cavity, right? So this is two spaces. The gut or whatever is developing from the gut is attached towards the anterior abdominal wall and the posterior abdominal wall by this mesentery, and that mesentery is named as the ventral mesentery and the dorsal mesentery, right? What happens as the lateral folds are formed? This ventral mesentery disappears and the complete single peritoneal cavity is formed, right? Towards the dorsal side we are getting the fold of peritoneum around which the viscera is hanging in the abdominal cavity. Right? So the most prominent part which we can see of the lower part of the esophagus, the mesentery proper towards the small and large intestine, somewhere it forms the organs as the retroperitoneum. Retroperitoneum, only on one surface the peritoneum is, or the serous pericardium, the peritoneum is covered, while posteriorly it is related towards the posterior abdominal wall. Posterior, retroperitoneal organ ka kya hoga? The dorsal mesentery, the organ is growing towards the posterior side, to the posterior abdominal wall, and this is getting adherent towards the posterior abdominal wall. Anteriorly only it is covered with this serous peritoneum, right? So this is how the single peritoneal cavity is formed. Okay, body cavities we have seen, pericardiac, two pericardioperitoneal canals forms the pleural cavities and the single peritoneal cavity. Understood? Are you able to write the answer if it comes as a question? Yes, good. So now we'll see the diaphragm. Okay? How it develops. So what are the parts of diaphragm? Diaphragm, what are the structures? Tissue you are getting here. What structure you are getting here when we see the diaphragm? Musculotendinous. It is having a muscular part and it is having the tendinous part, right? So it is a dome-shaped musculotendinous partition which is separating the abdominal cavity from the thoracic cavity. It is having attachments. It's a complete dome. So towards the central side we are getting the central tendon of the diaphragm. Towards the lateral side it is attached towards the lateral body wall, right? Anteriorly it is attached towards the sternum, while posteriorly it is attached to the vertebrae, transverse processes of the vertebrae, right? So that is the complete partition between these two large cavities. So actually this whitish structure which is depicted here shows the central tendon of the diaphragm, which is towards the central side. While here in the lower posterior part, towards the lower side, we can see the crusts are formed, right crust and the left crust. These crusts are attached towards the vertebrae, right? Transverse processes of the vertebrae, bodies and the transverse process. While the other part which we can see here, it is the muscular. right? So how this is developing? From the 4 sources. Diaphragm is developing from the 4 primitive sources. What are these? So it is composite. It is not arising from a single structure. It is arising from a different sources. So that's why it is named as a composite structure. First is the septum transversum, paired pleuroperitoneal membranes, dorsal mesentery of the esophagus. We have seen primitive gut, dorsal mesentery, right? And the mesoderm of the body wall. How the mesoderm of the body wall is responsible here? See, as the lung is growing, the costodiaphragmatic recess is formed towards the lateral side. Okay, it is deepened down, and that lateralmost part of the diaphragm is formed from the mesoderm of the body wall. Okay, that we'll see further. So just tell me about what are the other structures formed from the septum transversum? Yes. One we have seen this center tendon of the diaphragm. Any other structure which is developing from septum transversum? Yes. Liver is done. It is done in microanatomy as well as in gross anatomy. So how the liver develops? What is the structure when you see a liver tissue under microscope? Hepatocytes, the basic structure. Then, yeah, portal triad and the central vein. Anything else? Puffer cells. Okay. Yes. So hepatic lobules, how the hepatic lobules are defined or how it is formed? Cords. What cords? Yes. So that is the tissue cells. Now one hepatocytes. That is the arrangement only. Any other tissue which is formed here in the liver? Is what is the covering of the liver? So the Gleason's capsule is formed from the septum transversum. Well, the parenchyma means the hepatocytes and the cells which are lying, that is developing from which germ layer? Yes. The rest of the things are developing from which germ layer? The hepatocytes and everything in parenchyma lies is developing from what germ layer? Yes? Endoderm. Right? So which part? Foregut. The liver bud. Okay? So the hepatocytes in the parenchyma is developing from the endoderm, from the foregut, and the Gleason's capsule is developing from septum transversum. Anything else is developing from septum transversum? The fibrous pericardium. That is how when you are getting this specimen, this is fused towards the central tendon. Liver is also closer there, and fibrous pericardium is fused towards the central tendon of the diaphragm. Okay? So these are the 4 primitive structures from which the diaphragm is developing. Now we'll see first, we know the location of the septum transversum. Okay, before the head fold, it is the cranial most structure. Septum transversum, after that we are getting the primitive pericardiac cavity and then the precaudal plate here we can see. Right? So pericardiac cavity is lying dorsal to the developing heart just before the head fold. After the head fold, the septum transversum is going down, right? It is going down here, and cranial most we can see forebrain, then that comes the stomodium, the cardiogenic area along with the pericardiac cavity, and then comes the septum transversum. Okay, that is the relations after the head fold. So what is this? This is the mesodermal tissue. It is the composed mesodermal tissue, lies between the pericardiac and the peritoneal cavity. So here we are getting, this is the pericardiac cavity, and below here we are getting peritoneal cavity, and this is the septum transversum, okay, towards the ventral side. Dorsal to it we are getting the gut, foregut. So this primitive gut is having the dorsal mesentery towards the dorsal side, and that is forming the dorsal mesentery of esophagus. At what place? Towards the septum transversum. Where we are getting the septum transversum, we are getting this dorsal mesentery of the esophagus. Okay. Now what happens? Dorsolateral to the septum transversum, we have seen pleural and the peritoneal cavities are communicating with each other with the pleuroperitoneal canals. That is the relation of the septum transversum towards the dorsal side, towards the dorsolateral side. Okay. While the cranial part of septum transversum forms the which major part of the diaphragm? That is the central tendon of the diaphragm, right? So this is forming towards the ventral side and in the center, right? So this is the schematic image from the Keith Moore, which we can see in the B, C and D. See this part, okay, the ventral part, major part here is formed from the septum transversum. Okay, this is the central tendon which is formed from this septum transversum. Okay. Further we know here the pleuroperitoneal membrane is formed at what place? Pleuroperitoneal canals. This gets closed by the formation of the pleuroperitoneal membrane, right? And they fuse with the dorsal mesentery of esophagus and the septum transversum. Once the membrane is formed, this membrane is fusing ventrally towards the septum transversum, and towards the dorsal side it is fusing with the dorsal mesentery of esophagus that we have seen in the primitive gut, right? So the dorsal mesentery of esophagus, that is the mesentery, constitutes the median portion of the diaphragm. So here, yeah, this part is forming the crus of the diaphragm. Okay, right crus and the left crus of the diaphragm is developing from the myoblast that goes into the dorsal mesentery of the esophagus. So here we can see this the peach color area which is shaded here is formed from the, that is forming the crus of the diaphragm, right? And this is developed from the dorsal mesentery of esophagus. Further, there is the growth of the lateral body wall. Okay, muscles are developing here. The lung is growing. That is how the pleural cavity is growing towards the lateral side. But towards the medial side, from the septum transversum, the central tendon is formed, right? But towards the lateral side, as this pleural cavity is growing, these races are formed. What are these races? Races means the space. Okay, to angle is formed, that is the costo-diaphragmatic angle, and in that the races is formed, right? So body wall tissue which is developing here splits into two. The external layer becomes the definitive abdominal wall, while the internal layer that contributes to formation of the peripheral part of the diaphragm. Okay, peripheral part of the diaphragm is developing from this lateral body wall. Okay, so here we can see this part, lightly shaded area in the lateralmost part, that is developing from the. So we know the dome-shaped configuration of the diaphragm is formed when it is formed in the complete diaphragm when it is formed. Okay, so lateralmost structure here, that is the body wall. So we'll see. Understood? 4 structures. What are these? Septum transversum, then pericardio-peritoneal membrane, or the pleuropericardial, all these are fused here. Pleuroperitoneal membrane, then dorsal mesentery of the esophagus and lateral body wall. Okay, these are the 4 sources. Now what happens? What is the nerve supply to diaphragm? What is the root value? C3, C4, C5. Where is C3, C4, C5? Nerves arising in the neck region. In the cervical region. Where is the diaphragm? That is lying towards the thoracic vertebrae. That is the partition here. Okay, between the thoracic and the abdominal. So why this happens? There is the changes occurs in the diaphragm. Positional changes occurs. Okay, and the descent of the diaphragm is happening here. So around at the 24 days of intrauterine life, the septum transversum is lying at the level of the 3rd, 4th and 5th cervical segments. Okay, that is how there is the nerve supply to the septum transversum. As the diaphragm is descending, it takes the nerve supply along with that, right? So approximately at the 41 days, we can see this is the position of the diaphragm, right? Separating the heart and the liver here. While around approximately after the 6th week, 52 days after the approximately 52 days here, we can see this is the normal position of the diaphragm between the pericardium and the peritoneal cavity, right? That's how it justifies the nerve supply to the diaphragm. Okay, it is taking its nerve supply from the cervical region, and it is lying just lateral in the mediastinum, the phrenic nerve. The course of the phrenic nerve, it lies in the mediastinum, related to the medial side of the lungs and the lateral side of the heart, right? And it goes here down and supplies the diaphragm. That is the development of the body cavities and the development of diaphragm, right? Now we'll see the congenital anomalies. So most common congenital anomalies along with the diaphragm we are getting here, that is something named as a CDH, congenital diaphragmatic hernia. That is a more common in babies. The other one is the eventration of diaphragm, then retrosternal or the parasternal hernia or Morgagni hernia, and the congenital hiatal hernia. First we will see what is the congenital diaphragmatic hernia, that is also named as the Bogdalic hernia when it is present towards the left side. So how is in this image we can see the content or the things, structures from the peritoneal cavity is reaching towards the thoracic cavity, covering with the, there is a gap here, okay, and that gap, through that gap it is going in the thoracic cavity. So here this is the most common, right, Bogdalic hernia. What is the defect is named as posterolateral defect. Posterolateral defect. And what that posterolateral part of diaphragm is formed from which source? So where is the problem here? So we'll see features. What are the herniation of the abdominal contents into the thoracic cavity. What is mostly herniated? Stomach, spleen, and the most of the part of the intestine is herniating in the thoracic cavity from the abdominal cavity. How the baby is coming with the symptoms of the breathlessness, cyanosis, and unusual flat abdomen, because the contents from the abdomen is going towards the thoracic cavity. So this is life-threatening, breathing difficulties may be associated. That leads to, there is something named as the pulmonary hypoplasia. Lungs are very small. That is not normally developed. Okay. So fetal lung maturation is delayed. So here pulmonary hypoplasia, 85 to 90% of this defect is towards the left side. Why? Yes, right canal, right pericardio-peritoneal. The pleuro-peritoneal canal fuses earlier than the left side. So this majority of the time the defect is on the left side. So here we can see the X-ray of the diaphragmatic hernia. Defect is posterolateral. What is happening here? Failure of the pleuroperitoneal membrane formation. So pleuroperitoneal membrane is not normally formed. That's why there is a gap towards the left side in the posterolateral side. Towards the posterolateral side. So what we can see here, heart is shifted towards the right side, while on the left side we can see the Coils of intestine, the stomach is going towards the thoracic cavity. So intestine here, it is completely filling up towards the thoracic, left thoracic region, right? So this is how there will be the signs on the radiograph. The other congenital anomaly which we can see here is the eventation of diaphragm. What is eventation? Abnormal formation of the muscular component of the diaphragm, right? So here diaphragm is formed. There is a partition, but it is weak. The muscles are weak. That's how these structures are going in the thoracic cavity along with its sac, along with the diaphragm, right? So abnormal contour of the diaphragmatic dome is seen here. That is named as the eventation of the diaphragm. There is something named as the congenital epigastric hernia. So what we can see here, swelling is seen towards the umbilicus, right? What is happening? This is an uncommon hernia. What is the most common? Dogtail-like hernia, left posterolateral defect due to faulty formation of the pleuroperitoneal membrane, right? This is uncommon. What is happening here? This uncommon hernia occurs towards the median plane, right? So also named as a gastroschisis or epigastric hernias, which is resulting from failure to fuse the anterior abdominal wall. After the lateral folds are forming and they are getting fused anteriorly, it is not properly fused, right? That's why there is the hernia occurs here. Something is protruding from the abdominal cavity. What is herniating most of the time? Small intestine. That may be detected earlier by the ultrasonography. There is something named as the hiatal hernia. Hiatus means what? Yes? Opening, right? So this is the herniating. The things are herniating towards the opening. What opening is that? Esophageal hiatus. So there may be herniation of the part of stomach or the other things. Excessively large esophageal hiatus. Okay, there is a normal opening of the esophagus in the diaphragm which is reaching towards the stomach. But here what happens, this opening is excessively larger and that is named as the hiatal hernia. So although hiatal hernia is usually acquired lesion, it occurs in adult. Well, the other things we have seen that is occurring in the babies, right? Here, what is the predisposing factor? Enlarged hiatus. Enlarged opening may be the predisposing factor. There is something named as a retrosternal hernia. Retro means just below. Sternum, just below the sternum. What space is there? Foramen of Morgagni is present and the structures are herniating through this foramen of Morgagni. Sternocostal hiatus. That opening is named as the sternocostal hiatus. This is located between sternal and the costal parts of the diaphragm, right? As it is attached to the lateral body wall, that is the costal fibers. Sternal fibers towards the sternum, inner aspect of the sternum. So what happens here? Large defects are commonly associated with the body wall defects in the umbilical region. If it is very large, it is named as the omphalocele. Omphalocele, okay? That's it about the congenital anomalies, right? Now we'll see one video which is depicting the formation of intraembryonic coelom, the cavities and the diaphragm. Yes? By this sound, intraembryonic coelom here, okay? So two layers of the mesoderm are splitted to form the splanchnopleuric layer and the somatopleuric layer. normal position of the diaphragm.